Hey everyone, I, Dr. Achla Ingle, welcomes you all to study with me an important medical emergency that is pulmonary embolism topic. Now, I by myself have detected and diagnosed many of the pulmonary embolism cases which were presented to me with deep vein thrombosis. And yes, the ECG says it all, and we need to suspect it. We need to do CTPA, and let's learn more about it so that we could diagnose more of these life-threatening cases. So it could be a thrombus embolism or it could be a non-thrombotic embolism. Now, talking about a non-thrombotic embolism, so they could be because of amniotic fluid, because of tumor, fat embolism, septic embolism, or air embolism. Now, we have a hemodynamic classification of pulmonary embolism which says it could be divided into a massive or a submassive or a small. Now, the occlusion, depending upon the occlusion, it could be more than that of 50%, it could be a 30 to 50%, that is a submassive one, or it could be less than that of 30%. And there is the highest risk of mortality associated with massive pulmonary embolism. So coming to its pathophysiology, so this is an embolism, as you could see, and this is the pulmonary artery that is getting occluded. So if it is occluded, then the blood which is present in the right atrium and the right ventricle will not be passing through the pulmonary artery. So what will happen? The heart will bulge from the right atrium and right ventricle. Now this is very important that there is the right ventricle and right atrium dilatation occurring, and so this can push this side also, and this can push this side also, right? This right atrium bulging and right ventricle bulging. So what will it cause? So there will be decrease in the volume of left atrium and left ventricle. Now what will it cause? So if there is decrease in the blood in the pulmonary artery, so naturally there will be decrease in the blood in the pulmonary veins also, and that will lead to, so this will lead to decrease in the blood in the left atrium and left ventricle, and eventually there will be decrease in the cardiac output as there is no blood which is passing through the aorta. So this is the pathophysiology, overall pathophysiology. So there is obstruction of the pulmonary artery, there is bulging of the right atrium and right ventricle, there is less blood to pulmonary artery, and there is decrease in the left atrium and left ventricle volume. So there is decrease in the cardiac output. So we have the symptoms of pulmonary embolism as hypertension, shock, right, and arrest. Many of times the patient is giving history of chest pain also, and there is dyspnea. So there is decrease in the coronary blood flow. Now this is very important that we should detect right atrium, right ventricle dilatation. In on the X-ray also we could see that there could be a significant right atrium, right ventricle dilatation, right? So if there is any of the injury to the muscles or there is any significant dilatation occurring, so NT and proBNP levels will be raised. Like that of in case of pericarditis or myocarditis and MI. So there is this on 2D echo we could see that there is, this is an apical wall and this is the free wall. So there is this right ventricular free wall hypokinesia, which is called as the McConnell sign. This is the embolism which is actually a saddle shape embolism, right? So this is the dilated pulmonary trunk, and this is a massive pulmonary embolism, so patient may be landing up in a hemodynamically unstable condition. So management, we all know that it should be a thrombolysis followed by that of any of the low molecular weight heparin. We will see the doses and everything of it. Now any patient who is receiving a casualty, when patient is collapsed, and then you need to perform a CPR, right? And now after 48 hours of doing the CPR and everything, now you come to a diagnosis. You get to do the 2D echo, and then you see on the 2D echo that there is a right atrium, right ventricle dilatation, and you know that this is in pulmonary embolism. So what should you do? So you should continue CPR, and while giving the CPR you should give a bolus dose of tenecteplase, and Then continue CPR for 60 to 90 minutes, right? Not only for 30 minutes, it is 16 to 90 minutes. Now this is in MI also a newer update, and this is in pulmonary embolism also a newer update, that in even in the MI, whenever the patient is in ambulance itself, we can give a 10 milligram dose of tenecteplase. Like that, or even in pulmonary embolism, it is suggested that you could give a tenecteplase bolus dose. So we have this flow chart which is saying that if the patient is suspected, which is hemodynamically unstable, then we need to do a transesophageal echocardiography. Now this will be telling us if the right atrium and right ventricle is dilated or not. Now if suppose the right atrium, right ventricle is not dilated, then we would not be touching the patient. Now if the patient is having the dilatation, then we need to proceed with the CTPA, which is a confirmatory, right? This is the gold standard, we could say. So the and on CTPA, if we say that there is this we can do CTPA, then if it is a positive one, then we need to start on the treatment. If it is a negative, we cannot, right? We should not. But there are certain centers that CTPA is not available. Then what to do? Then straight away start with the treatment, right? We need not worry that we should be confirmatory or something like that. If you have the ECG, if you are suspecting it, go ahead and do it, because 2D echo says it all. So mortality wise, if we say that there is if there is any massive pulmonary embolism, so overall it is almost 60%, 60 to 65%. So let's see, if the patient is even treated, that should be a mortality of 20%. That means we need to have a close monitoring of this patient while lysis, after lysis, and even after 2 days of the lysis, right? With a shock, there is almost 25 to 30% of the mortality, and with the resuscitation, it is almost 65%. So overall, it is 65% mortality. Coming to a submassive form of the pulmonary embolism, that means the 30 to 50% occlusion has occurred. Now, wherein there won't be any hypotension, and other things would be same like that of massive pulmonary. That means the troponin will be raised, there will be NT-proBNP levels will be raised. Okay, but the hypotension part is not present. So, okay, RA-RV is dilated, normal BP, NT-proBNP levels are raised, and troponin levels are positive, right? Coming to the management, we need to lyse the patient of the submassive. We can lyse it, or we can give just the low molecular weight heparin. Then we have the small pulmonary embolism. That means this patient is having less than 30% of the obstruction, and here the patient presents to us like a pneumonia patient. He would be having cough, he would be having B symptoms, or like that, or constitutional symptoms rather, I say. Fever, fatigue, and all that, and but there should not be any air bronchogram. So that means there would be any no air, and there won't be any air bronchograms, as well there won't be any troponin, there won't be any hypertension. Okay, so RARV is not dilated, so and the ECG could also be normal. So we are not very sure of the diagnosis in this patient, and it is a tricky one. So the RARV is normal, the biomarkers could be normal, and only on the CTPA we can have the embolism. So we need to suspect. This is very important. So management over here is not lysis, it is only low molecular weight heparin. So why should the patient be dyspneic? So it could be a circulatory collapse, it could be a VQ mismatch, or it could be a right to left shunting. So what is the strong predisposing factors, right? So many of the massive surgery, that could be one thing. Then could be a fracture or any major trauma or spinal cord surgery, and hip or knee replacement. Coming to moderate predisposing factors, likewise, it could be because of malignancy, because of ossiples, because of chemotherapy, because of pregnancy or postpartum, or any of the thrombophilia factor is positive in that patient. Okay, so we need to suspect, we need to search for the risk factors in each and every patient. Weak predisposing factor, that means any bed rest which is more than that of 3 days, or obesity, varicose vein, or increasing age. So we have this well-known Wells criteria. So that will help us to see if the patient fits in the criteria, and we need to perform a D dimer, and we need to perform the CTPA or not. So there is a classical Wells criteria and there is a simplified Wells criteria. So in the classical Wells criteria, we have given fancy marks to one of the component, and in the simplified Wells criteria, we have only one plus mark, right? So the any of the signs of the DVT signs and symptoms, we will allot him 3 marks. 3 points. Then alternative diagnosis, which is less likely than of the pulmonary embolism, that is also a 3. Then we have a heart rate which is more than that of the 100, that is 1.5. Immobilization surgery within that of the 4 weeks, that is also 1.5. Prior DVT or pulmonary embolism, that is 1.5. Hemoptysis and cancer, that is 1 and 1. And in simplified we have 1. So any of the 4 or any of the 1 is considered to be the of that of the simplified, and that of the classical, we can say that this is a diagnostic for that of pulmonary embolism. Coming to the ECG shows poor sensitivity, but yes, the most common part is the sinus tachycardia. We remember S1, Q3, T3, but not it is not so uh, typical. It could be an S1, Q3 also. It could be just the T inversions. It could be an RBBB, anything like that. So development of the S waves is actually commenting upon that the patient is having a right axis deviation on his ECG. Chest X-ray has poor sensitivity, so we have certain markers that could be an MCQ for you. Westermarck sign, that means there is a focal algemia of the lung, and then we have the Hampton sign. This is a wedge shape opacity that will be present. Then there is a Pala sign, that is in right descending artery which is enlarged. Then we have Flesher's sign, that means there is a linear band of atelectasis. D-dimer is to rule out, right? 2D echo is done only in a hemodynamically unstable patient. Now, if the patient is hemodynamically stable, what should we do? So, if the patient is hemorrhaging stable, we need to see if the patient is an outpatient or if it is an inpatient. Now, if it is a patient is an outpatient, we can do a D-dimer in him, right? We have certain time sparing, right? So, D-dimer, if it is a negative, then we need no treatment. If it is a positive, then we need to do CTPA. If the CTPA is negative, then there is of course no treatment. If it is CTPA is confirmed, we need to treat the patient. Now again, there is a high clinical suspicion, and we need to indoor the patient, and patient is dyspneic and everything. He has the symptoms and everything, and then we need not do D-dimer. We can straight away do CTPA, and we can um, treat the patient if the patient has the pulmonary embolism on CTPA. So CTPA is a method of choice. VQ scan is only done whenever the dye is not favorable for the patient, that is in renal failure, in pregnancy, in any allergies to the dye. Then pulmonary angiogram is not done. Okay. So treatment, coming to treatment, the first step is to stabilize the patient. So we need to put the patient on the NORAD and inotropic support. Then the thrombolysis or anticoagulation could be done, and then parenteral anticoagulation, which is given up till day 5, and then we can shift the patient to oral anticoagulation. So we would see one by one how to take the patient on the any of the anticoagulation, or when and how to start the lysis. For the first step, stabilization, we need to have vasopressors, and anticoagulation, parenteral anticoagulation is started. Now, thrombolysis is only in massive thrombus. We all have seen. In submassive also, the literature says, but I haven't seen any patient of submassive being lysed. Then thrombolysis to be done as early as 48 hours, so that the young thrombus will respond to the lysis very well, and it could be done up to 14 days. So we have the SPECI score, remember this name, for deciding if the thrombolysis to be needed or not. Now, what are the benefits of thrombolysis? So that the patient feels better, he has a decrease in mortality, recurrence rate is lesser. This will help us to manage the heart failure also, and there is accelerated clot lysis and tissue perfusion. So it will decrease the pulmonary hypertension and chronic thromboembolic hypertension also. Now, there is obviously a risk of intracranial bleed and cerebrovascular accident. So it is in 1 to 2% of the patients, and it is done within that of 48 hours. We have seen it. Now, coming to the regimen, most we use altiplase or streptokinase. Now, coming to the dosage part of streptokinase, it should be given 2.5 million international units over 30 minutes, followed by that of 1 lakh unit over 12 to 24 hours. And if we need to have an accelerated dosing, then we can give 1.5 million international units over that of 2 hours. Coming to urokinase, in the urokinase 4,400 units per kg over 10 minutes to be given, followed by that of 4,400 units per kg per hour for 12 to 24 hours. And accelerated dosing we can be given within that of 2 hours. That means it should be given 3 million units. Altiplase, which is only FDA approved. Okay, so it is the only one which is FDA approved, and it should be given within that of 2 hours itself. And so the 100 milligram dose is enough. And accelerated part we give to 0.6 milligram per kg over that of 15 minutes. Now there is obviously a bleeding risk. Now in case of elderly, it is mostly seen. So we could just half the dose, or we could go with embolectomy, or we can go for catheter directed thrombolysis. Some of the centers have it, some of the centers cannot, right? So embolectomy, when is the embolectomy done? Whenever there is the risk of bleeding, or there is failed lysis, or in case of intracardiac thrombus and hemodynamic patient is unstable. So but it has a high mortality. Okay, it is not done, even though technically simpler, but it is not done. Then we have a parenteral anticoagulation. Parenteral anticoagulation, we have low molecular weight heparin, we have fondaparinux, and we have unfractionated heparin. So coming to the low molecular weight heparin, the dose is 80 units per kg, followed by that of 18 units per kg per hour. And then we have low molecular weight heparin. That means it is 0.6 cc subcute BD. Fondaparinux, it should be 7.5 milligram OD, but in case of the weight, depending upon the weight, if it is less than 50, then 5 milligram per subcute, or if it is more than 100, then 10 milligram subcute. That is the parenteral anticoagulation. That means after the lysis, we need to start on any of these. Okay, and we are it to be given up to day 5. Now coming to the oral anticoagulation, that means the patient has to be shifted on oral country so that it could be discharged. So on day 3, there are certain of the anticoagulants that need to be overlapped, and there is no need of overlap in case of others. So there is one dabigatran, and we have endoxaban that should be given after 5-day course of the heparin, that is dabigatran 150 milligram BD and endoxaban. And coming to the patient could be directly started without the heparin. That means that is an apixaban, which is given 10 milligram BD, that is for the 7 days, and followed by 5 milligram BD. Or we have rivaroxaban, that could be given for that of 15 milligram BD for 21 days, followed by 20 milligram OD. So how long to give? So it is said that if the patient has we cannot find any of the cause for that of pulmonary embolism and DVT, then the patient need to be closely monitored, right, and to be given lifelong anticoagulation. But the certain articles say it should be for 3 to 6 months, followed by if the recurrences rate is less than that of 3% per year. Okay, so we have already seen that ESC says that recurrence rate is high, so lifelong anticoagulation to be given. But we also say that then if there is an unprovoked venous thromboembolism, and though no cause is found, then we need to give a lifelong anticoagulation, right? So this is all. Thank you for watching. Bye bye.